Hello everyone and welcome to our module on osteoarthritis. The term arthritis refers to joint inflammation, and typical symptoms of arthritis include joint pain, warmth, and stiffness of the joint. And there are many subtypes or causes of arthritis. I've listed a number of them on the slide here. In this video we're going to focus on osteoarthritis, which is the most common form of arthritis. It's the form you're most likely to see clinically. It happens to many elderly patients. Osteoarthritis involves the synovial joints. So synovial joints are found all over our body. They include many joints in the fingers, the hips, the knees, and all synovial joints look like what's on the screen here. So you've got two bones that come together. Each bone is covered by auricular cartilage, and then on the outside there's a membrane called a synovial membrane. And then within the joint space there is synovial fluid. So this is the typical structure of a synovial joint. Couple of high yield things to know about this, especially in terms of step one. The auricular cartilage is made up of type 2 collagen. That's the type of collagen found in cartilage. And the synovium or the synovial membrane secretes synovial fluid that fills the joint space, and a major component of synovial fluid is hyaluronic acid. There are two key elements of the pathophysiology of osteoarthritis that you need to know for step one. The first one is that in this disorder, hyaline cartilage breaks down. So remember, the hyaline cartilage is on the surface of the bone. So when it breaks down, you get bone on bone, and that's what happens in osteoarthritis. Now, most people know this, but what you may not know is that important to this process is abnormal function of chondrocytes. And there's a lot of basic science literature on this, so it's important that you know that the chondrocytes play a key role in the pathophysiology of osteoarthritis. Chondrocytes are the only cell type found in hyaline cartilage, and they are normally quiescent, but they begin to proliferate in osteoarthritis, and they attempt to repair the cartilage, but the repair is inadequate. They secrete enzymes like proteases. They also secrete cytokines, and this all contributes to the inflammation and breakdown in osteoarthritis. And then eventually they die, and this leads to the exposure of bone. So make sure you know that it's the hyaline cartilage and the abnormal chondrocytes that are key to the development of osteoarthritis. Even though there are cytokines and inflammatory cells involved in osteoarthritis, if you sample the synovial fluid, you will find a relatively low white blood cell count. And for this reason, osteoarthritis is referred to as a non-inflammatory arthritis. Now, this term is technically incorrect because there is inflammation going on in osteoarthritis, but what people mean when they call osteoarthritis non-inflammatory is that the white blood cell count is much lower than it is in other forms of arthritis that are considered inflammatory. Let's take a look at the table on the screen here. The normal white blood cell count in synovial fluid is less than 200. In osteoarthritis, it can range from 200 to 2,000, but it's never more than 2,000. In rheumatoid arthritis and gout, for example, the white blood cell count is typically in the tens of thousands. It can range from 2,000 to 50,000 in both RA and gout. And then septic arthritis is famous for having the highest synovial white blood cell counts. In septic arthritis, it can be greater than 50,000 and even up into the hundreds of thousands. If you take an X-ray image of a joint affected by osteoarthritis, there are a couple of classic X-ray findings that you should be aware of for step one. I've listed all of them on the slide here, and we'll go through these in the next few slides. The first one is joint space narrowing. So on the left side of the screen is a normal knee joint. On the right side of the screen is a knee in a patient with osteoarthritis, and it's very easy to see that the space between the two bones is decreased and the bones are closer together. And like I told you before, the hyaline cartilage gets destroyed and you have bone on top of bone, so it's very easy to understand why there would be narrowing of the joint space. Subchondral sclerosis refers to thickening of the subchondral bone, which is the bone that sits just below hyaline cartilage at the edge of the joint space. When the hyaline cartilage breaks down, you have exposed bone, you can have bone rubbing on bone, and this leads to thickening of the subchondral bone. There can be more collagen laid down, the mineralization can become abnormal, and what this means in terms of an X-ray is the bone will become bright white at the edge of the joint space. You can see that here in this picture. There's a black arrow pointing to it. We've got bright white bone right here at the joint space. That's the bone that would normally sit below hyaline cartilage, the subchondral bone, and that's evidence of subchondral sclerosis, a characteristic finding of osteoarthritis. Osteophytes or bone spurs are also seen in osteoarthritis. These happen because of thickening of the subchondral bone at the joint margins, often at the insertion points of tendons or ligaments. So if you look on the left side of the screen, there's a bone spur right here. I've zoomed in on it so you can see that there's this bone growth out from the joint. That's an osteophyte or bone spur. And lastly, you can see on X-ray subchondral cysts. These are fluid-filled sacs at the edge of the joint. These happen because the bone breaks down and forms cracks, and synovial fluid fills the cracks and accumulates, and this leads to a finding called a subchondral cyst. There's one shown on the screen here. There's a white arrow pointing at a black space in the bone just off the joint space. That's a subchondral cyst that you can see in osteoarthritis. Osteoarthritis commonly involves the knee, and when it does, it often involves both knees. That's because when we stand, we put a lot of weight on our knees. And it turns out that we bear more weight on the medial side of our knee compared to the lateral side. So on imaging, you may see asymmetric narrowing on the medial side. This is an example of that shown on the screen here. You can see that the medial side here is much narrower compared to the lateral side. Osteoarthritis often involves the hands. It classically involves the joints at the ends of the fingers, so the DIP joints and the PIP joints, but usually not the MCP joints. And this is an important contrast with rheumatoid arthritis, which often involves the MCP joint. So if we look at this drawing on the screen here, the DIP joints are usually involved, the PIP joints are involved, but not the MCP joints right here. And in terms of the thumb, the classic joint to be involved is the first carpometacarpal joint, which is this joint right here at the carpal bones. On this slide, I've shown a drawing of the hand bones next to an x-ray of the hand bones, and I've indicated the joints that are involved. It tends to be the joints at the ends of the fingers. And the way I've always remembered this is that osteoarthritis occurs in elderly patients, so it occurs at the end of our lives and it occurs at the ends of our fingers. That's always worked for me. And here's one more picture with an actual hand. They like to show you x-rays or pictures of people's hands and ask you which joints are involved. So I've indicated here, again, it's the joints at the ends of the fingers that are typically involved. In some patients with osteoarthritis, they develop swellings in the joints of the fingers, and when this happens, those swellings are called nodes, so this is called nodal osteoarthritis. There are two types of nodes that can be seen in osteoarthritis. Heberden's nodes are the distal nodes, and Bouchard's nodes are the more proximal nodes. I'll show you a picture of this in a minute. These occur in patients who already have osteoarthritis involving the interphalangeal joints of the hands. Over years, the joints become less painful and the inflammatory signs subside, but then these swellings or nodes develop and remain behind. They're common in the index and middle fingers in particular, and these are believed to be caused by osteophytes that are left behind from burned out osteoarthritis. Here's a picture of a patient with nodal osteoarthritis. These more distal nodes are called Heberden's nodes. Nodes at the more proximal joints are called Bouchard's nodes. So we've talked about the knees and the fingers. Now I'll run through some of the other joints where osteoarthritis can develop. You can see osteoarthritis in the spine. The facet joints are synovial joints. The facet joints are the connection between two vertebrae. They're shown in purple in this picture on the screen here. In particular, the facet joints of the cervical spine often lead to neck pain, and the facet joints of the lumbar spine often lead to lower back pain. The hip is another synovial joint often involved in osteoarthritis. This is a drawing of what osteoarthritis looks like. The hyaline cartilage has broken down and there's exposed bone and the joint space is narrowed, and many patients develop hip pain from osteoarthritis. So we've kind of talked about this, but let me go over some details about the symptoms of osteoarthritis. So the hallmark is joint pain, and this is joint pain especially after use of the joint. Osteoarthritis is considered a wear and tear lesion on joints. It often happens in elderly people, which we'll talk about in a minute. So as you use your knee joints or your hips or your fingers through the course of the day, that will lead to pain in those joints, especially at the end of the day for weight-bearing joints like the hips and knees. This is a classic time for those joints to ache in people with osteoarthritis. And overnight, as the patient rests, the symptoms will improve. In addition to joint pain, many people with osteoarthritis complain of stiffness and restricted motion of the joint. The major risk factors for osteoarthritis are shown on this slide. Advanced age is a risk factor. 80% of patients are over 55 years of age. Female gender is also a risk factor, and shown on the screen is a picture of my grandmother to remind you of the typical demographic, an elderly female. And remember what I said before, if you remember, osteoarthritis occurs at the end of people's lives. That can remind you that it involves the joints at the ends of the fingers. Obesity is the most important modifiable risk factor for osteoarthritis. You can't do anything about your gender or your age, but you can control your weight, and if you do that, you're less likely to get osteoarthritis. This is especially true at the knee. Many obese patients develop osteoarthritis of the knee because their knees bear more weight compared to an average person. And in addition to the knee, obese people also get more osteoarthritis involving the hands and the hip. And then finally, if you've suffered a joint injury to a joint, for example, in the knee or the hip, maybe from a fall or a sports injury as a child or young adult, you are later more likely to develop osteoarthritis in that joint. Treatments for osteoarthritis are listed on this slide. Exercise and weight loss are lifestyle modifications that are very helpful in improving osteoarthritis. It may seem counterintuitive that using the joint with exercise would improve, but patients who are stronger and healthier tend to be able to tolerate the breakdown of the joint better. Pain control is often administered with acetaminophen, which is Tylenol, or nonsteroidal anti-inflammatory drugs, and a very common reason for patients taking chronic NSAIDs is osteoarthritis. Some patients will go to their physician, often an orthopedist, who will administer a glucocorticoid injection into the joint. This is somewhat controversial. It provides short-term pain relief, but it's not been shown to help the joint over long periods of time. However, many patients like these because they provide immediate and short-term pain relief. And then finally, surgery is often indicated for osteoarthritis. If you go into orthopedic surgery, you will spend much of your time operating on knees and performing total knee and hip replacements for patients with osteoarthritis. I'll finish this video by running through a couple of conditions that can sometimes be confused with osteoarthritis. So let's start with rheumatoid arthritis. So in the immunology section, I have an entire video on rheumatoid arthritis, and the reason it's in the immunology section is because rheumatoid arthritis is an autoimmune condition. It's common in women who are aged 40 to 50, so a much younger demographic compared to osteoarthritis. This is a picture of Lucille Ball, who was an actress, and she's the typical type of person to develop this condition. In contrast to osteoarthritis, if you sample the synovial fluid from a joint in rheumatoid arthritis, you will find a high synovial white blood cell count. I showed you a table earlier showing that the usual white blood cell count is up to 50,000 in patients with rheumatoid arthritis. It's much lower in patients with osteoarthritis. Rheumatoid arthritis classically has morning stiffness and pain that improves with use. These are different from osteoarthritis. In rheumatoid arthritis, as the patient rests at night, inflammatory tissue builds up in the joints, and therefore when the patient wakes up, they are very stiff and painful. As the patient uses the joints, the inflammatory tissue is broken up and it becomes easier to use those joints. This is the opposite of osteoarthritis. And then finally, because rheumatoid arthritis is an autoimmune condition, it has many systemic complications outside of the joints. So patients with RA often have uveitis, serositis, Baker's cysts, and I talk about all of these things in the video in immunology, but you shouldn't see any of this stuff in osteoarthritis, which is a disease process entirely confined to the joint. Septic arthritis is another arthritic condition that can sometimes be confused with osteoarthritis. Septic arthritis has an acute onset, so very different from the slowly progressive onset of osteoarthritis. In addition, osteoarthritis often involves multiple joints, whereas septic arthritis classically involves swelling and pain of a single joint. And you should be aware that if a patient presents with an acute onset monoarthritis, meaning an acute arthritis of a single joint, that's a medical emergency. You need to tap that joint and exclude septic arthritis or gout. Both of these are serious conditions that can progress and destroy the joint. Septic arthritis can even progress to sepsis and death. So you don't want to ever ignore the acute onset of a monoarthritis. In osteoarthritis, patients usually don't have an acute onset. They present with slowly progressive symptoms of multiple joints. In addition to the joint symptoms, patients with septic arthritis often have systemic signs of infection like fevers, chills, and sweats, and you should never see these things in osteoarthritis. And then, as I told you earlier in this video, if you tap the joint of patients with septic arthritis, the synovial fluid will have a very high white count. It's considered purulent and has white blood cell counts ranging up to 150,000, much higher than anything you see in most other forms of arthritis. And then, of course, if you send the synovial fluid for a gram stain and culture, it will be positive, indicating the presence of bacteria. Typical bacteria that cause septic arthritis include Staph aureus and Strep pneumoniae, and when these bacteria cause septic arthritis, it's often because they're in the bloodstream, so it's hematogenous spread that seeds the joint. So patients who have a septic joint from one of these bacteria usually also get an evaluation for bacteremia or endocarditis or other signs of blood system infection. And then Neisseria gonorrhea can also cause septic arthritis. As you may know, this is a sexually transmitted infection. So in a board question, this is often going to be a sexually active young person who develops the acute onset of joint swelling. The last disorder I'll mention that can be confused with osteoarthritis is hemochromatosis. I talk about this disorder in a video in the GI section, but by way of review, hemochromatosis is an iron overload disorder. And you should be aware that arthritis is very common in hemochromatosis. If you ever meet anyone with hereditary hemochromatosis, one of their main complaints will be that their joints ache. And in fact, this disorder sometimes presents as arthritis before any of the other features of the disorder develop. Most commonly, it involves the MCP joints, and remember, these are usually not involved in osteoarthritis. It often presents with pain and minimal swelling, and the way to distinguish this, at least in board questions, from osteoarthritis is that it will usually be a younger patient, not an older patient like typically develops OA, and then usually at some point in the question stem they'll mention that the serum ferritin is elevated, and if you see this, you should think that this may be a case of hemochromatosis. Very commonly leads to arthritis and can be confused with osteoarthritis. And that concludes our video on osteoarthritis.